of cervical spondylotosis by Dr. Kanwaljeet. Garg.
I'm sorry for this trouble. A warm good afternoon to everyone. I would like to thank the organizers for giving me this opportunity to share our experience on managing traumatic cervical spondylotosis patients. As we all know, traumatic cervical spondylotosis is an extreme form of spondylolisthesis which involves all the three columns of spine. It indicates complete segmental disruption. It's an uncommon but devastating injury. Very few case series involving few patients have been reported in the literature. The management of these patients is not uniform, and a number of different management options ranging from conservative management to 540-degree fixation has been advocated in the available literature. We did a retrospective study in which we included all the patients who were managed for cervical spondylotosis at our trauma center, which is in Apex Trauma Center, from January 14 to January 20. And preoperative CT and MRI of all these patients were studies as well the clinical details. We could find 10 patients who were managed during the study period for traumatic cervical spondylotosis at our center. And the mean age of the patients was 35.7 years. Most of the patients had suffered road traffic accident. All the patients had quadriparesis. 6 patients had fascia A injury, while 3 patients had fascia D injury. Associated injuries included hemothorax, long bone fractures, head injury, hepatic injury, and other vertebral fractures. 9 patients had anterior listhesis, while 1 patient had rectal listhesis. The commonest levels involved were C5-6 and C6-7. The CT findings included fractures of the facet, vertebral body, pedicle, or laminar fractures, while the MRI findings included cord contusion, cord transection, extruded disc, and ascending cord edema. All the patients were managed by a surgical intervention, and spondylotosis was reduced in all the patients. Mean interval between injury and surgery was 30 days, while it ranged from 1 day to 8 months. As our center is in a referral center, so we get most of the patients referred from other centers. Hence, the interval between injury and surgery is quite long in our series. Though as soon as we get patient, we tend to operate them at the earliest slot available. Regarding the surgical approach, 5 patients underwent 360-degree fusion, anterior first followed by posterior. 4 patients underwent only anterior surgery, while 1 patient underwent anterior, posterior, and anterior approach. There was no change in ASIA grading of any of the patients following surgery. 6 patients had to undergo post-operative tracheostomy for the need of ventilation. And the surgical and the postoperative complications included CSF leak in 3 patients, meningitis in 1 patient, ventilator-associated pneumonia in 3 patients. And 3 patients died following surgery during their hospital stay. So coming to some case examples, this is the first case, a 28-year-old male who met a road traffic accident, and he presented to us 10 days after the injury. On examination, he was ASIA A below C6 level and with absent anal tone and perianal sensations. He also had bilateral hemoneurothorax. This is how his CT looked. There was C6-7 spondylotosis, and the superior and inferior facets were fractured on one side, while on the other side there was only fracture of the inferior facet. The MRI of this patient revealed anterior compression by the extruded disc. So we did an anterior approach first. We could remove the disc and the other compressing elements. However, we couldn't reduce the spondylotosis. Hence, he was turned prone, and we did laminectomy and 4-level fixation, 2 up and 2 down, and we could reduce it from the back after drilling the facet joints. Then he was turned supine again, and the Eilers press graft was placed, and an anterior cervical plate was fixed. This is the second case, a 43-year-old male road traffic accident, ASIA A below C5 level, showing C5-6 spondylotosis. This is an intraoperative radiograph showing the spondylotosis being reduced intraoperatively. And this is the post-operative X-ray in this patient we only did anterior fixation because his chest was very bad and he was not in a condition to undergo posterior fixation in the same setting. Third patient, a 25-year-old male, road traffic accident, ACIA on examination. He had rectal C6-7 retrospondylotosis, and the parasagittal section showing side fractures. And he also underwent anterior corpectomy and cervical blade cage placement and cervical plating. Coming to the mechanism of injury of these spondylotosis cases, most of these result from high-speed motor vehicle accidents. So we had 3 or 4 patients in our series who had fall from height, or it can also result from diving accidents. The common mechanism of injury in this patient is compressive extension. What happens is the hyperextension leads to fracture of the posterior elements, while the resultant vector, because of these two forces, pushes the superior vertebral body anterior and inferior to the inferior vertebra. Actually, it's a 5-stage injury, and all stages have been nicely described in literature. Flexion destruction is another common mechanism of injury in these patients. What happens is that this distraction destabilizes and unhinges the facet joints, and while the flexion it forces the superior vertebral body ahead of the inferior vertebral body. Neurological status, it depends on the presence of cord compression in these patients. In our series, most of the patients had varying degree of spinal cord injury, with 7 patients having complete or ACIA or B. However, few patients can be neurologically intact even despite having spondylotosis. This happens when there is fracture of the posterior elements of the vertebra, which slips forward, which results in natural decompression due to widening of the cervical spinal canal. And there is no kink of the spinal cord whenever there is fracture of the posterior elements. Whenever there is a resultant kink of the spinal cord, the patient will have some form of spinal cord injury. Investigations, cervical X-ray is usually the first investigation which is done for these patients when they land up in casualty. And whole spine CT is also advocated in these patients. CT is essential to understand the bony anatomy of the fracture, and it's also essential for surgical planning. While CT of the rest of the spine is essential to rule out any other fracture which can be there, as was there in one of our patients. CT and MR angiography has also been advocated. It has been advocated. It is done to rule out any concomitant vertebral artery injury. MRI cervical spine is done to rule out any anterior cord compression because of extruder disc hematoma or fracture fragment, as well as it also tells us about the cord, status of cord edema. The pre-surgical management of these patients starts at the scene of accident in the form of immobilization of the neck in hard cervical collar and following the cervical precautions while shifting these patients to hospital. Now, is there any role of traction in this severe form of spondylolisthesis? The answer is yes, because the goal of any intervention, surgical or non-surgical intervention, is stabilization of unstable fracture dislocation to prevent any further neurological compromise. The traction is an immediate and indirect way to achieve this because it restores the anatomical alignment apart from providing stability. It all can increase the diameter of the cervical spinal canal and thus reduce the compression of the spinal cord. It may also restore the anatomical alignment and may convert a spondylotosis to a lower grade spondylolisthesis. The prerequisites for traction in any patient with spondylolisthesis or spondylotosis include that the patient has to be conscious, and MRI, preferably MRI should be done to exclude anterior compression because a herniated disc can be seen in 1/3 to 1/2 of the patient with facet subluxation. And there should be an emergency OR available in case if the patient deteriorates following application of traction, then the patient has to be rushed to OR immediately. The role of surgery in these patients, surgery is essential because it can achieve bony decompression and it may improve the prognosis if the patient has spinal cord injury. It also results in fixation and stabilization of the spine, and thus the nursing care of the patient becomes easy. It is important because it is not the injury but the complications of these quadriplegic patients which eventually kill the patient. Regarding the timing of the surgery, the surgery should be done as soon as possible, irrespective of the time from the injury. And early decompression results in better outcome. And if there is a significant delay following injury in operating the patient, it is difficult to reduce the fracture dislocation. This is our management protocol. We always get an MRI cervical spine once we get a patient of cervical spondylosis, and if there is any anterior compression, the patient is taken to OR and anterior cervical approach is done first. And after the compression has been relieved, then we try open reduction. Most of the times we are able to achieve that because there is extreme instability in these patients. And if open anterior reduction is not possible, then the patient has to be turned prone, and then facets has to be drilled, and the deformity has to be reduced from back, and then the patient has to be turned supine again to fix the cervical spine from front as well, as was done in the first case which I showed. If there is no anterior compression and the patient is awake and the prerequisites of traction are met, then a pre-op traction can be applied and a closed reduction can be tried. And then, depending on the result of traction, the further management can be done. Certain tips and tricks. Preoperative traction can be helpful, and if there is deterioration following application of traction, then the patient should be shifted to OR. Neuromonitoring can be helpful, should be used in the patients who are neurologically intact, like the three patients who were Asia D in our series. And in case of CSF leak, a lumbar drain should be used, and ideally one should do a 360-degree fusion as it's a three-column injury. Cold injuries are difficult to be reduced completely and they may require a 540-degree approach. Low cervical vertebra are difficult to visualize under fluoroscopy, especially in patients who have short neck. And an intraoperative CT scan may be helpful in these patients. To conclude, traumatic spondylosis is a severe injury. Most patients have complete spinal cord injury and the prognosis is very poor and the management is also challenging. Thank you for patient listening.